The topic which I want to discuss today is about a cardiac patient of different variety for which comes across anesthesia practice. Okay, so am I audible to you? Am I? Please mute yourself. Am I audible to all of you? Is my voice clear to you?
Yes, sir.
Okay. So if I ask you that what may be the symptoms and signs, what do you think when you have a cardiac patient? What do you think? What can be the problems and how will you evaluate that patient? Yes, Zunaira?
Sir, there are a lot of things that we need to consider before
Like
to evaluate the comorbidities, starting from cardiovascular system, hypertension, the state grades,
just a second.
NIHA class, NIHA.
Just a second. I will rephrase my question. That if you think that there is a cardiac patient, how will you evaluate that? What will be the what will be the signs and symptoms would you like to see? What are the common cardiac symptoms, for example, or what are the things which the patient will tell you, or you can find?
Sir, orthopnea, dyspnea.
Okay, dyspnea. Okay. Orthopnea. What else?
And paroxysmal nocturnal dyspnea.
Okay, this is also sort of dyspnea.
And
dyspnea on exertion.
And SOB on exertion.
Okay.
Exertional dyspnea.
What else?
And the function class of the patient.
Okay.
But it will not include symptoms.
What else? What else? What about cough?
And sorry, sir?
Cough. Cough with sputum. In case
yes, sir,
cardiogenic pulmonary edema.
Yes, sir, of course.
What about chest pain? What about palpitation? Because you know why you are not able to answer this question? Because you people only live in the books. Okay. If you will come out of the books, you will find a different world. Okay. So history of palpitation, chest pain. What about, have you heard of intermittent claudication? Can there be cyanosis in heart problems? Just a second, please. Think more. Let me. Yes, please. Are you getting my point of view? Okay, so these will be there you will find a number of more, like in cardiac patients, because of
history of syncope, the patient suffering from the arrhythmias. The history of syncope, the patient is suffering from the arrhythmias or any sort of stenosis.
Syncope. Okay, syncope. So what else? Edema can be a sign, edema can be a symptom. Okay. Then can there be abdominal pain in heart problems?
So epigastric pain.
Epigastric pain.
Vague epigastric pain.
And even right hypochondrial pain.
And chest pain. Chest pain with the characteristic radiation and intensity and associated factors.
Yes, right hypochondrial pain because of hepatic congestion. Okay. So like just you can just think about it. So you will find that and actually whatever is the problem is, well, for example, heart, if there is any problem related to its blood supply, so what will be the result? There will be ischemia. Okay. And then when there will be ischemia, either it will become like in the form of MI, in the form of arrhythmias. Okay. There may be acute valvular regurgitations, and at the end failure. Okay. So this will be the sequence of event if ischemia occurs. If, for example, patient has valvular heart disease, so in the valvular heart disease, whether it is stenotic lesion or whether it is this regurgitant lesion, okay, what will ultimately occur? That either there will be enlargement of heart chambers, okay, stasis, there will be development of atrial fibrillation.
Inadequate filling, reduce stroke volume.
Yes, cardiac output will not be sufficient. Okay. And then this, if this back pressure will be acting on lungs in acute way, it will develop pulmonary edema.
Pulmonary hypertension.
And if it is in chronic, it will develop pulmonary hypertension. Okay. So usually in one way or other, it will be like that. Valvular heart disease. Okay. So there will be increased transvalvular pressure.
Transvalvular gradient.
Transvalvular pressure gradient. And then what will happen that the dependence of atria, left atria will be more, the click. So if, for example, atrial fibrillation occur, patient will not be able to maintain the cardiac output. Okay. Similarly, if there is, for example, aortic stenosis, so aortic stenosis and actually hypertension, the effect will be almost the same, that there will be hypertrophy. Okay. So when there is hypertrophy, what will occur? The cardiac filling will be decreased because compliance will decrease. So what will happen? That there will be diastolic failure. Okay. So this is the common pathway. Even if it is hypertension, it will almost have the same effect. The course of event will be the same: left ventricular hypertrophy, decreased compliance, decreased filling, dependence on atrial click, and ultimately systolic failure will occur later on. Okay. So this is just a sequence of events. So similar findings you will find in the symptoms. So again, come back to either it will be presented as chest pain, as we discussed, it will be having cough with sputum, or any other signs of failure, intermittent claudication. And yes, directly it is not cardiac, but if CVA occurs, okay, or peripheral vascular disease occurs in the form of this limb ischemia, okay, it is indirectly also considered as a cardiovascular symptom. Okay. Because if the patient has symptoms of peripheral vascular disease, there are more chances of CVA and TIA and stroke. Okay. So this will be one of the picture. And then if you have patient with hypertension, or for example, if you label as ischemic heart disease, so whether it will be stable angina, okay, or unstable angina resulting in infarction. Okay. So you should be understanding what is going on. Like, for example, if you have a patient with hypertension, some few more words about hypertension. That hypertension will be affecting, first of all, heart. Similarly, there will be chances on the problem in the brain, and then in the lungs. Okay. Can you please mute yourself? Okay. So what you say as micro, in lungs, then kidneys, then eyes, okay, and indirectly other system. So you label them as microvascular or macrovascular. Okay. So microvascular complication will be in the retina or in kidneys, and macrovascular will be in the brain, in the peripheral vascular disease, and in the heart. So whenever you are evaluating a patient, you will either have microvascular complication, retinopathy, in the form of this visual field, vision problem. Okay. And
Retinal
kidneys,
hemorrhage.
yes, and kidneys, there will be proteinuria. Okay. And ultimately the changes of CRF with cortico-medullary differentiation is lost. Okay. Similarly, in brain, either it will be TIA or stroke. It may be both can occur, but usually in acute hemorrhagic crisis, there will be, in acute crisis, there will be hemorrhagic stroke, or if it is a part of peripheral vascular disease and ischemic heart disease, it will be ischemic stroke. So whatever you are looking at, you have to evaluate in this way. Okay. So now you can add on some of more symptoms accordingly. But whenever you think that there is a cardiac patient, you will be looking at the patient with this eyes. If you it is said that eyes cannot see, but mind does not know. So if you haphazardly just try to open a chart and asking the question like a nursing staff, so you will not get anything. Okay. So that's why whenever you are looking at it, even for example, I have just mentioned to you ischemic heart disease. I have mentioned to you hypertension. I have mentioned to you valvular heart disease. What else? Cardiac failure. Okay. And some of the, you can say, cardiomyopathies. Some of them will have the same, and congenital, this cyanotic congenital heart disease, cyanotic heart disease. Okay. So if you consider even anything of it, majority of the thing which I have told you will be like that. Similarly, like if you find some symptoms, then you will go for signs and symptoms. So sign and symptoms will be symptoms I have discussed. Signs will be failure signs. Okay. Like for example, JVP raise. Okay. Edema, sacral edema, or pedal edema. Okay. What else? Crackles. Okay. This hepatojugular, so this one, hepatic congestion. Okay. So that will be a sign. What else? What will be the sign? Sign in the journal vital signs. Okay. So there may be changes in pulse. Okay. There will be maybe blood pressure. And then when you auscultate, there may be signs of some heart sounds. There will be some problems in the heart sounds. Okay. And the next step will be, there may be some missing beats. Okay. In pulse, you will find the rate, the rhythm. Okay. And then there may be difference in different pulses in different scenarios. Okay. But this is generally how you should evaluate a patient. And then next step will be investigations. Okay. So what will be the investigation? ECG, echo. What else? Thallium scan, exercise tolerance test, cardio pulmonary exercise testing, chest X-ray. What else? CT angio. Okay. Holter, ambulatory blood pressure. Okay. What else? ECG, echo, Thallium scan and yes, angiography. One thing I missed before was placement of either pacemaker or in acute situation. Pacemaker or this what modern say AICD, or this will be actually in acute situation only. Intra-aortic balloon pump, left ventricular assist devices. Okay, so this is very special scenarios. Otherwise, usually you will find either of them. And how will you interpret? So when you are looking at ECG, you will be looking at the rate, rhythm, okay, and then P wave, PR, QRS, QT, any signs of ischemia, infarction, okay, any changes related to electrolyte imbalance, okay, then access, hypertrophy. So usually whatever we have discussed before, so it will have effect here, okay. So for example, if there is a ischemic heart disease, there will be some signs of ischemia or infarction, okay. If there is a hypertrophy, you will find some changes of hypertrophy, okay. Similarly, if there is some arrhythmias, you will find some problems in the rhythms. There will be some problem in like in heart failure, P pulmonale or P mitral. If there is some blocks, if the coronary is related to the conducting system of heart will be changed, then there will be some blocks, okay. So this is how you will be interpreting, but normal ECG doesn't mean anything. If you have a patient with suspected thing, you will have to do the exercise tolerance test. So if the patient is not able to move, and so either you will do exercise tolerance test or cardiopulmonary exercise testing. So like if you the patient have some physical limitation which is not letting the patient assessed in that way, then you will have no other option than to go by pharmacological stress testing, okay. So in that way you will either go for, because what is the rationale of thallium scan? It is to see the perfusion defects, okay, perfusion defects. And now a few words about echo. So usually whenever we see the echo, actually the only thing which we are looking at is ejection fraction, which is the least important thing, believe me. It is the least important thing. So if you see the echo, the least important thing is ejection fraction. If it is more than 55, it will not tell you anything. Yes, if it is less than 50 or less than 40, for example, or if it is low, then it is significant. If it is more than 55, it is written, it doesn't mean anything, because early changes will be as diastolic failure. Okay, the changes which will be there in heart will be related to diastolic failure. So believe me, in hypertensive patient or even in ischemic heart disease patient, if you see ejection fraction normal, it doesn't give you any information. Okay, so you have to look at the diastolic failure pressures and what you say, that how much is dependence from the atrial contraction. Okay, atrial contraction. So that is the report which is written is E/A ratio. Okay, so as much usually this will be more and this will be less. E is the normal ejection, which is occurring passive ejection from atria to ventricle, and it is showing if it is normal, E/A ratio will be more than 1. Or but if it is, for example, the part of A is increasing gradually, and the heart filling is more and more dependent on the atrial contraction, this ratio will be changed. And by this way, they decide how much diastolic failure is there. Okay, so this is the concept of that thing, and that is more important. Other finding which you can see is any like chamber changes like camber clot or some changes in the pressures. Then you can see in valvular heart disease, you see the size, valve size, or you see the transvalvular pressure gradient, okay, or you see the regurgitant fraction. Three things usually you see. And if there is like atrial fibrillation, so there you'll be find a clot, so it's a danger sign because that can cause embolism. Okay, so similarly you see the pulmonary pressures, so it will give you a rough idea about pulmonary artery pressure, but exactly if you want to check, you will have to do the right heart catheterization if you want to see the pulmonary hypertension. Okay, similarly, the very important thing which you find in echo is the vena cava compression. Okay, vena cava compression. So vena cava compression, it will tell you fluid responsiveness. Okay, so for example, if you have a patient in hypotension and you see the vena cava compressibility, that it means that patient needs fluid. Okay, so similarly, like chambers, and yes, one more thing which is related to echo, related to ischemia, is that usually what will happen, regional wall motion abnormalities. Okay, it will lead to hypokinesia, and then it will lead to akinesia, and it will lead to failure of that part. So this will result in systolic failure. Okay, so this is the first thing. You will now, if you just recall any echo report, so you will find these things written over there. So you have to interpret like that, that if you have ischemic heart disease, you will either find region wall motion abnormality, and actually these findings are more so when you are doing T. Okay, you will find these findings more so in T. So thallium scan, they will put a dye as this but isopyramidol, what you put, I don't remember exactly what they use in thallium, because they give a stress to the heart, and then they say the perfusion defects. They visualize the perfusion defect. So if there is any perfusion defect, then the next step will be going towards angiography. So that is the sequence of events. If they find perfusion defects, then they will go for angiography. Similarly, if they want to, there is some functional limitation and the patient is not able to move, how will you assess? Because usually if you want to see the physical activity, you will ask whether you are able to go on 2 flights of stairs, and so it will be more than 4 mets. Okay, so but if, for example, patient is having osteoarthritis, patient cannot move, so how will you evaluate? So in that way, you have to do the stress testing. Okay, so pharmacological stress testing, so it will be stress thallium or dobutamine stress echo. So in that way, you will be able to see whether the heart is able to tolerate the stress or not. Okay, so on these bases, on whatever I have told you, you will evaluate either active cardiac conditions, which are also in some books written as major cardiac predictor. Okay, and the number thing second thing is intermediate predictor, or what you say as clinical risk factor, or in some you will also Lee's revised cardiac risk index, okay, with surgical risk, like if it is emergency surgery, so it will include, but these are all the same thing. And the minor predictors, and usually whatever arrhythmias you are finding, the minor arrhythmias or hypertension without any end organ damage, this is only a minor predictor, it is nothing. Okay, so the active cardiac conditions is, can anyone, because only I am speaking. If anyone else want to speak out, do anyone know about active cardiac conditions or major predictors? What are those? Acute, recent, MI. 7 days or 30 days. Okay. Then unstable angina. Okay. And you quantify it on Canadian class. So Canadian class 3 and 4. Okay. So it is dyspnea on mild exertion or dyspnea at rest. So this is 3 or 4. So this is one factor. These are two factors. Then there is decompensated heart failure. And you classify it as New York Heart Association class. Actually, they are almost the same. Here they say chest pain, and here they say signs of failure. So again, it is New York Heart Association class 3 and 4. And it is saying that like patient is having failure symptoms on mild exertion or at rest. Okay. Then the other is severe valvular heart disease, like mitral stenosis, tight mitral stenosis, or tight aortic stenosis, critical. Okay, severe. And then severe arrhythmias, like for example SVT or VT or heart blocks. Okay, so significant arrhythmias. So these are active cardiac conditions. And actually, if you don't have these active cardiac conditions, there is no way to cancel a case without these things. So because the next step will be clinical risk factors. So clinical risk factors, here it was acute MI, here it is old MI. Okay, there it was unstable angina, here it is stable angina. Okay, so same 1 and 2. New York, this Canadian class 1 and 2. There it was decompensated heart failure. It is here compensated heart failure. Okay, so it is New York Heart Association class 1 and 2. Then you have diabetes mellitus, which is insulin dependent. And then you have CRF with creatinine more than 2 or more than 176 micromole. Okay, and then you have history of CVA. So you will find if there is 2 or more risk factors, then you will go for text like echo or this thallium scan. Like for example, if you have a patient with hypertension or isolated old age, there is no indication for echo. But we are sending the patient. Patient is hypertensive, send for echo. You will see whether you have anything like that. Then you will refer for echo. Okay. And one more thing which will be which need to be considered in this regard is the 2 other factors you will see. You will see the functional class, that whether patient how much is mobile. Okay, and then the surgery which is done. Is it high risk surgery or intermediate risk surgery? Okay, like functional class mean METs. Okay, and intermediate risk surgery or high risk surgery or low risk surgery according to that. So you will only do if there is intermediate or high risk. Low risk surgery, like for example incision drainage or hernia surgery. Okay, superficial breast surgery. So these are not leading. This is not that much stress that you are sending the patient for investigation. Intermediate risk surgery like body cavities, like for example laparotomy or laparoscopic surgery, okay, or thoracic surgery, or high-risk surgeries like liver transplant, like vascular surgery, major vascular surgery. Okay, so you will find a list of high-risk surgery, emergency surgery. So these are considered as high-risk surgery. But of course, in emergency, you will not send the patient for echo. Emergency, you have to proceed. But it is considered as, you will find a list of diseases which are considered as high-risk surgery. Okay. So that's how you will chalk out your investigations. And if you find next step, you will go for intervention. Like you will have to decide whether you have to do that surgery first, or you have to do the cardiac intervention first. So it will be according to multidisciplinary team. You will outweigh risk versus benefits, and then you will decide whether, like for example, the patient, sometimes they are having, they found to have this one carotid blockade, who are planned for cardiac surgery. So at that time, they have to decide which thing they have to manage first. Okay. So this is just an overview. Similarly, you will find the rest of the findings are chest X-ray or this one cardiac CT. Okay, to see the patency of the vessels and things like that. Okay, so like any questions or any comments up till now? Yes, please. Understand or not? Okay, so in next step, what will happen that if you find such patient, then you will need, in addition to the normal NIBP or ECG, okay, the normal monitoring, standard 1, standard 2 monitoring, you will go for invasive blood pressure, okay, invasive blood pressure monitoring or cardiac output monitoring, okay, or CVP or pulmonary artery catheter, or this non-invasive cardiac output monitoring. And what else? What else? T. Okay. Then in these patients, you might need to have access to like, for example, pacemaker, okay, or defibrillator pad, okay. Then for example, vasopressors or inotropes, antiarrhythmics. Okay. And then what else you will do? You will try to have medications which are less cardiac depressant. Like for example, you may consider etomidate. Okay. You may consider cisatracurium in place of medication which are releasing histamine. Or for example, among the opioids, you will try to avoid pethidine or tramadol, okay, which may cause tachycardia. In the reversal, whenever possible for you, you will consider, for example, either Sugammadex, or you will give glycopyrrolate. You will try to avoid atropine. Okay. So what else would you like to do in these patients? You will avoid stress. You will have multimodal analgesia. Okay. What else? Procuronium is good. Procuronium is good. Okay. Anyways, so you will be considering these things. Okay. You might need to have HDU. These things which I have discussed with you is true for either hypertension, ischemic heart disease, valvular heart disease, heart failure. I'm not discussing any specific disease, but this discussion, if you just think from where we started, from just simple cardiac symptoms, signs, then some investigations, and now how to interpret and then correlate with the comorbidities from where Zunera started, that we will look at the comorbidities. Okay. So actually, this is a whole picture you will have in your mind whenever you are, you come to know that you have a cardiac patient. Okay. So I hope you understand. So any questions, please? And again, yes, Dr. Humera?
Sir, certain drugs are vagolytic, like muscle relaxants or pancuronium,
Pancuronium also,
and
yes.
maybe
Pancuronium I missed. Okay. So you will use, that's what I told you, that you will use citracurium. You will use morphine. Okay. The other day someone was asking that why you.
and sir,
I'm
what
sorry?
about sir, have you ever experienced any patient getting infarcted or having MI during anesthesia? Because we have never seen this.
Don't pray that you don't see. Okay. Pray that you don't see. I will just answer your question. Yes, Dr. Awais, what's your question?
Sir, my question is, if let's say we have a patient having very low ejection fraction, like 32%, and he is having regional wall motion abnormalities and etomidate is not available. So how we are going to proceed with induction by using propofol and inhalational anesthetic? Please share some experience with us.
Actually, for exam point of view, you don't need to answer that. Okay. For practical purpose, if you ask me, I never use etomidate. I always use this cocktail with some midazolam. You will be mad at me, but ketamine, fentanyl, multimodal analgesia. Okay. So this will make a combination that you are using a titrated doses of propofol. Okay. Midazolam, ketamine, fentanyl. You are using paracetamol before induction. You are using, say, NSAID before induction. Usually we don't do this. Okay. But if you do like that, you will see a wonderful effect. Okay.
And then what about the maintenance of anesthesia? Do we still use these isoflurane, or we got ketamine, like Tiva with maybe ketamine or some other
Yes,
thing?
actually, I am a Tiva lover, but sevoflurane, isoflurane, because all these medications have dose dependent effect usually. Okay. Desflurane causes tachycardia. Isoflurane causes tachycardia. Sevoflurane is relatively stable. It maintains, but again, I tell you that if you are using in high MAC, so any gas will cause problems. Okay. So there is no fixed rule. If you are using, for example, dexmedetomidine, it will give you a great cover. Okay. If you are using morphine, like for example, morphine has cardiac in the other way as well. So morphine, you see, Mona, which you pneumonia, which you use morphine, oxygen, nitrate, aspirin. Where if there's a patient with failure or ischemia. Okay. So actually, because this was an overview, and I just try to, like the question which Dr. Humera asked, that what can be the problem. So I have discussed in detail multiple times. I will share the link for those discussions which I had before. Okay. So you can review, like echo we discussed once in detail. Okay. And you can have that discussion in YouTube. You will find in the playlist. Okay. So similarly, intraoperative arrhythmias in cardiac patient, what will expect? So you will expect ischemia. You will expect MI. You will expect arrhythmias. Okay, you will expect shock, things like that. So you have to be ready for those things and anticipate blocks. Yes, Wes, any other question?
Yes, sir. I have a second question. That can we use intravenous xylocaine to blunt upper airway reflexes at induction in patient with ischemic heart disease using beta
Yes.
blockers? My question is, there will be any interaction between beta blockers and IV xylocaine? And second, third question is,
You know,
sir,
your voice
having
is very distorted. Yes, please be a little loud. What is
okay,
your
sir. I'm going to be a bit loud. Can we use IV xylocaine at induction in a patient using beta blockers? Could there be any interaction between beta blockers and intravenous xylocaine to blunt upper airway reflexes? And third question is, sir, how can we use ketamine in these patients in combination with propofol in titrating doses? Just share your experience with us.
You know, actually, your voice is not clear to me. You are asking that how will I add ketamine?
Sir, have you understood my second question?
No, I'm
Sir,
sorry.
xylocaine.
Xylocaine and beta blocker, I understand that. Would I use lidocaine and beta blockers together? That's what your question is.
Yes, sir. And the third is the combination of propofol and ketamine in these patients.
Yeah, actually, you know, remember one thing, one answer is theoretical and one answer is practical. I use ketamine in every patient in low dose, around 20 to 25 milligram. Okay. And similarly, lidocaine is used as infusion. Throughout this, you are only talking about bolus. I will say even you can use it in infusion.
Even if the patient is using beta blockers, sir.
Yes, you will titrate. You know, there is no fixed dose for these things. Okay, this is related to the stress. This is related to the overall situation. Okay. So you in certain conditions, IV lidocaine, I have used it myself, 0.5 to 2 milligram per kg per hour lidocaine infusion. Okay. So of course, if patient is having beta blockade, and so requirement of lidocaine will be reduced. And you will not use all medications in one patient. Like in one patient, you will not use lidocaine infusion and dexmedetomidine infusion, and like you will choose different patients and you can have a combination. Okay. So if you are using, for example, lidocaine and dexmedetomidine, for example, together, you need to reduce the doses accordingly. Okay. Otherwise, and what will be the effect on all these things? Even I forgot to mention gabapentin. Gabapentin is being used to reduce reduce the MAC and very, very stable patient with reference to analgesia. So the use of regional blocks, this is important. Okay. Because in books, you will only find lidocaine in your holy book of Morgan Manhus. You will only find the boluses. You will not find lidocaine infusion. So that's why if you are only relying on that crap book, you will not know that there is something like that. Okay. Similarly, you will have only a tunnel vision. So practically, if you ask me, I don't use, because etomidate, it's not needed actually. And etomidate, theoretically, it says that it will cause adrenal suppression. So I don't need actually, because I use a combination. I use a cocktail, and even I tell you something, that in adult patient, I hardly ever use more than 50 milligram of propofol. Hardly ever. So you can understand this thing. Okay. So thank you very much, all of you. And any questions? All of you are welcome. So we will have some other.
What about the fluid management? Because I think you didn't talk about the fluid management. Is it
Fluid
do we
management.
still manage them like in these other patients? Fluid.
You know, the general concept will be that you will be doing the goal directed fluid management. Okay. You will set some goals and then you will try to if that, for example, the patient has limited cardiac reserve, ejection fraction is low, and the patient has valvular heart disease, so you will be a little judicious in fluid, and you can have cardiac output monitor, which will tell you the parameters like pulse pressure variation, like, okay, so a stroke volume variation. So what will happen that you will be able to identify when and if patient needs fluid. Like you can have, if for example you have the facility of assessing the volume status with the T, it will tell you the T, or even transthoracic, you can put the probe in epigastricum and you can see the fluid, this vena cava compressibility. Okay, so in that patient you will be then you will monitor the signs of overload. Okay, you will monitor the urine output. Okay, you will be looking at, because these patients are sometimes volume deficit, volume depleted. Like for example, if you have a chronic hypertensive patient, that will be volume depleted. So if you give any medication, the response will be even more. So maybe this patient needs more fluid in that regard. Okay, so but if you give too much fluid, so you can have a combination of crystallite and colloid. And another important thing, thanks for reminding me, because I had not mentioned these things about maintenance of good hemoglobin, because oxygen carrying capacity will be reduced if hemoglobin is not maintained. Okay, so you need to maintain the hemoglobin, and you can have a combination of crystallite and colloids. Okay, so it was a very good question. Thanks for asking the question. Okay, so thanks a lot. Actually, this was not for a specific cardiac disease, but we entered almost all cardiac diseases. Okay, because even if you have a patient with cardiomyopathy, same principle will occur. If you have a patient with the except or specific thing like pericarditis or pericardial effusion, even then it will be considered like a failure, and you have to drain it if you have this pericardial effusion. So I have just given you an outview. And remember one thing, ejection fraction is the least important thing in cardiac if it is more than 55. So this is my message. Evaluate the patient objectively. Sometimes you are only asking for something without any evidence, without any need. Like if you are ordering echo in a normal hypertensive patient, there is no sense. There is no requirement. Okay. So things like that. Okay. So thank you, all of you. Inshallah, we will meet again. Thank you. Bye-bye.